get started. So, intro to dental insurance. Now, this is a hot topic for dental offices across the country, as I'm sure you know, and something that, aside from the shutdowns, is super, super important. So, normally, when I give a presentation like this to a group of people, I will say in the room, anyone who has ever submitted a claim to an insurance company, stand up. And all but one or two people who are super shy will stand up. And I will say, everybody who is standing, you are all felons. That may be a little overkill, but I want people to understand the importance of what we do and doing it correctly. So, I want to make that, put that out there quickly. Delta Dental, everybody's best friend, is very, very good about telling their patients what you can and cannot do. And I do want to make a point to say, this is whether you are in network or out of network, these rules apply. It doesn't matter, well, I'm not in network with Delta, so I can do what I want. You cannot. You cannot routinely fail to charge or collect co-insurance, co-pays, deductibles. You can't do it in or out of network. If you fail to collect a copay or deductible without notifying the insurance company, you are engaged in overbilling, which is a form of fraud. You cannot conceal other dental insurance. You cannot perform treatment that is not needed. We all know that. The big thing, you cannot submit a claim for a covered service when you actually did a non-covered service. We had a call from a dentist a few weeks ago who was submitting claims for crowns, but was actually doing veneers. Some other dentist, I believe it was an endodontist, took an x-ray for the patient, submitted it to insurance. The insurance person, the reviewer, looked at that and went, wow, look at these veneers on the x-ray, but we have bills for crowns from last year. And he's going to be going through some trouble. So I want to make sure everybody understands that. And again, please, 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 if you have a question, if you have a thought, please use the chat, use the webinar chat, and I will do my best to answer as many as I can. So, one important thing to remember, no matter what, if it is not in the chart, it didn't happen. Documentation is key. And the days of writing your chart notes to say, I did a crown on number 14, full porcelain crown, two carpules of lidocaine, 2%, and that's the end of your note. They do not cut it anymore. You want those chart notes to be as complete as possible. Why are you doing the crown? Is there cracked tooth syndrome? Is there a fractured wall? Crack in a distal wall? Is there a fractured cusp? You want to have the whys in your chart notes to support what you do. I tell everybody, don't write your chart notes for you. Write your chart notes for the jury who's going to be reading them 5 years from now, because that's what matters. If the jury can read your chart note and know what you meant to do, you will be good. If they just see, did a crown on number 14, use 2 carpules of lidocaine, 2%, full porcelain crown, next visit delivery, that is not going to cut it. So please, please, please make sure your chart notes are complete, because they help not only with any potential litigation, which hopefully none of us ever experience, but also getting paid from the insurance company. And believe me, they look for as many reasons not to pay you as possible. So we're going to talk about some of those now. Just get through them as quick as we can, and move on to some of the more important stuff on how we actually get paid. So the clauses, all of the contract clauses that insurance companies use to get out of paying us. All right, number one, the missing tooth clause. This is a big one. I see this all the time, and you have to be asking about it. Okay. Missing tooth clause says if a tooth was missing prior to the start date of the policy, the replacement of that tooth will not be covered. So I see this a lot with bridges. The tooth was missing. Maybe the patient had a partial, or maybe they had nothing. You say, hey, we want to do a bridge. We're going to replace number 14 with a 3-unit bridge, 13, 14, 15. Insurance company says, well, we're not paying to replace that number 14 because it was missing the day the patient signed up for this policy. And unless you can show a clinical need for the crowns on 13 and 15, we are not paying for those either. And oh, by the way, you can't charge the patient. Okay, that's a big thing that they do, is if you are in network, you cannot charge the patient if the insurance company denies it for medical necessity. So please, please, please remember that. So when you're doing your verifications, please make sure you are asking about missing tooth clauses, because they are super, super common, and they are the way that insurance companies get out of paying for a lot of care, a lot of replacement. The next one is the least expensive alternative clause. This says we will pay for the least expensive way to fulfill whatever you are trying to do. So let's take a look at this x-ray here. So here we have a pano of a patient who's obviously missing 2 teeth on their lower arch. Best case scenario, and I think most dentists would agree, we're going to want to do 2 implants here to replace those 2 missing teeth. Implant, abutment, implant crown. However, we can't do that because the option, the least expensive alternative option says we're not going to pay for that, it's too expensive. So now we want to do a bridge. Well, that's not the least expensive alternative either. The least expensive alternative is a removable partial. That's what insurance is going to pay for this patient. They are not going to pay for a bridge. They are not going to pay for implants. If there is a least expensive alternative clause, they will pay for the least expensive alternative, which in this case would be a partial, again, subject to the missing tooth clause. So somebody asked, what is the option? Do we do the bridge for free? Do we do nothing? Well, number one, you want to know about that least expensive alternative clause. You want to know about that missing tooth clause in advance. Number two, what I would suggest, and this is something we're going to talk about on Thursday, if that patient has that, I would suggest a restriction request, which is a very specific HIPAA form that patients fill out that says, I don't want you to submit the claim for the bridge you're doing to insurance. I will post a link when I post this video onto the group. I will post a link as well to our website. It's practicemechanic.com. Click on the resources page, and on the resources page is our do not bill insurance form. Again, we're going to talk about it in a little more detail on Thursday, but that would be, Catherine, that would be the option. Other than that, if you are in network and insurance does deny it, you have to go by what the EOB says. In some states, you are allowed to charge the patient the difference. In other states, you are not. So, knowing that in advance is the way to go. The other option, like I said, is a non-disclosure request filled out by the patient, given to you, so you do not have to submit the claim to insurance. So that's what I would do there. again, any questions, please don't hesitate to ask. We'll get to as many of them as I possibly can before we end today. So the next clause that the insurance companies use to not pay you is a non-duplication of benefits clause. This comes into effect when a patient has a primary and a secondary or even tertiary insurance plan. The non-duplication of benefits clause basically says the secondary insurance will not duplicate coverage for that patient, which basically means until the patient has maxed out their primary, the secondary will pay nothing. They're not going to duplicate. Gone are the days of, insurance is going to pay 50% primary, 50% secondary, so your crown is going to be 100% covered, Mrs. Patient. Those days are over. So, non-duplication clause. The way it works here, if you are in network with both, all right, you do an exam. Your full fee for that exam is $100. Primary allows 70, secondary allows 60. With a non-duplication of benefits clause, primary will pay 100% of their allowance, which is $70. The secondary will pay nothing because the primary paid more than the secondary would have. If those were reversed, if the primary allowed 60 and the secondary allowed 70, in this case, the secondary would have paid $10. The difference between what the primary paid and what the primary paid and the secondary allows. So in that case, primary pays 100%, you'll collect $70, you write off the $30 difference between your full fee and the primary allowance of 70, write off the 30, and you're done. If you do a crown, your full fee is $100. Primary allows $800, secondary allows $7. Primary is going to pay 50%, which is $400. Secondary will pay nothing. So the patient will owe you their 50% of the primary allowance, which is $400. And you're going to do that write-off to get you down from the $1,000 fee down to the $800 allowance. And that's the way it works with a non-duplication of benefits clause on the secondary. Basically, if you have a secondary with a non-dupe, that secondary is in place for after the primary annual maximum has been maxed out. That's when the secondary will kick in. Again, if this was reversed, if the primary allowed 700 and the secondary allowed 8, in the case of the crown, the primary would have paid $350. The secondary would have then paid $50 to get what the insurance pays up to their allowance. And the patient is still going to owe $400. That's if there is a non-duplication clause. On the other side of the screen, if there is not a non-duplication clause, this is the way it always used to be. You do an exam, full fee is $100. Primary allows 70, secondary allows 60. Primary pays $70 at 100%. The secondary pays 100%, which is $60. You've now collected $130 from the two insurance companies. Technically, what you are supposed to do is collect the $100 you collect up to your full fee. And then you return the $30 overpayment, $30 over your full fee, your regular cash price, return that $30 to the secondary. You will typically have to call them and request that they request a refund from you. What you do not do is leave that $30 as a credit on the patient's account, or even worse, send a refund check to the patient for that $30 overpayment. A patient can never, ever profit from an insurance overpayment. Never, ever, ever. So call the secondary, request that they request a refund of $30, and then you get that refund number, you get that request, and you mail them in a check for $30. Same thing with a Crown. Your full fee is $1,000. Primary allows $800. Secondary allows $700. Primary pays 50%, which is $400 of their $800 allowance. The secondary pays 50% of their $700 allowance, which is $350. You've now collected $750 for the Crown, $50 more than the secondary allowance. And remember, in these examples, we're in network with both. You've now collected $50 more than your lowest allowed fee, which you are allowed to do. The patient will owe nothing, and you will do a $250 write-off to get down to the $750. If you have your system set up what I call correctly, where all of these numbers are being automatically calculated by your practice management software, and those write-offs are being taken at walkout. If you have EagleSoft and you have your fee schedules linked, your percentages entered in the edit employer, same thing with Open Dental, same thing with Dentrix. If you're posting that primary allowance to the ledger, which if your system is set up correctly, that's what you should be doing. In that case, you may have to do a debit adjustment. You may have to increase the balance because let's say the primary allowance was $700, that's what's posted to the ledger. You collected $750. Now you're going to have to do a debit adjustment to offset that $50 overpayment between the total paid from the two insurance companies and what's posted on the ledger. So again, never, ever, ever leave a credit on a patient's account from an overpayment from an insurance company. Do a debit adjustment. If you know it's one that's going to have a refund request attached to it, or you are going to ask the insurance company to request a refund, please, please, please do an adjustment, get that credit off of the account, and be prepared to cut that check when the insurance company sends you their request. So for the Crown example, somebody asked, don't we have to accept the lowest fee schedule, in which case patient would pay only $300? Well, they have a non-duplication clause, which means their coverage does not kick in until they have maxed out their annual maximum. So in this example, no, you would collect the $800 or the $400 because their secondary coverage does not kick in because of the non-duplication clause, does not kick in until they have maxed out their primary insurance. So no, in that case, you would collect that. You normally do accept the lowest fee schedule, but remember that coverage is denied. There's going to be no reimbursement under that because of the non-dupe. So that's why we skip that. And again, this is kind of a beginner overview look. We are on Thursday going to discuss out of network, in network, a bunch of different examples and look at actual EOBs from different insurance companies when we talk about secondary and primary. That's getting a little deeper than an introduction look. But we're going to discuss that in great depth on Thursday as well. So a couple questions real quick before I move on to the next one here. Somebody said, how do we discuss with the patient that this is to their benefit, signing the do not submit to insurance? Because it's getting you paid. Really, and I will be 100% honest with you, there are very few examples that I can give you where it is to the patient's benefit, other than, what would you rather have, Mr. Patient? Would you rather have a removable partial, or would you rather have those two bridges? If it's not worth the cost for you to have those two bridges, by all means, let's submit it and let's do the partial because that's what your insurance will cover. However, do you really want to have that glass of water on your nightstand, take that partial out every night, drop it in, have to deal with putting the partial in and out every day, being careful what you eat, corn on the cob, depending on the teeth, blah, 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 blah. That's the discussion I would have. What is to their benefit is getting the treatment that both you and the patient have agreed that they want. If it just comes down to money, that there really isn't a benefit to them. If the patient says, I just want to do whatever my insurance is going to pay for, do the partial. They're not going to be happy with it. Have them sign the consent form for the partial, talking about all the possible positive and negative outcomes, and you go from there. But, other than coming down to just money, the benefit is the patient gets the treatment that the dentist has decided and the patient has decided is in their best interest, not some accountant working for the insurance company who says, this is what we're going to pay for. All right, somebody else said, if we know in advance a person has a missing tooth clause when presenting treatment, are we able to charge the patient? You can charge the patient depending on your state. It's actually being completed now, but we have a state-by-state non-covered services rule and also downgrades rule spreadsheets that are being worked on for our resource page. That's one of the things my team is working on while we're working from home, because we're not able to actually go to work and gather and remain 6 feet apart. So that's one of the things that will be up, but charging the patient short of them signing the do not bill insurance HIPAA restriction request, it depends on your state. I hate to leave you with an open-ended kind of cliffhanger answer, but it depends on your state. In some states, and there are 11 states that do not have a covered services, non-covered services downgrade rule. If you are in one of those 11 states, no, you cannot charge the patient. You charge what the insurance company tells you to charge. So it's very possible you could do a $3,500 bridge for the $986 allowance for a partial and don't even get your lab bill covered. That happens all the time. But that's in 11 states. If you're in one of the other 39, then there are rules depending on the state. And again, we are working on getting those up, so they'll be on our resources page. And as soon as they are, I will post a link to it in the group as well. So the next scenario is the no out-of-network payment clause. Okay, used to be this was only HMOs, DHMO plans. Now there are things called EPOs, which are exclusive provider organizations. There are even PPO plans that will say there is no out-of-network payment. This can work in one of two ways. Either number one, it acts like an HMO and will not provide any coverage for you going to an out-of-network dentist. Or number two, a lot of deltas are doing this and saying you went to an out-of-network provider, which means we're not allowing assignment of benefits. We're going to send the check directly to the patient. A lot of you who do not participate with Delta have seen this already. Delta will send the check to the patient, not to the out-of-network provider, even if you have elected assignment of benefits and the patient has signed them over to you. Delta just will not pay. One of the ways they get the patient to realize, wow, if I would have gone to an in-network provider, I would have saved $119 that day. It's just their game to get their patients to go to an in-network provider to save money for both the insurance company and the patient. But it does remove the ability for the patient to select their own dentist if they have a no out-of-network payment clause. And again, it's not just DMOs, HMOs, DHMOs that are doing this. There are PPO plans now that will not pay to an out-of-network provider or provide coverage if the patient sees an out-of-network provider. So, something else you definitely want to ask when you're doing your verification. The next one is risk-based plans. These are increasing. These just started about 2 years ago, 2018. They continue to grow. A lot of large companies have gone to risk-based plans. If you look them up, you will see a lot of the Silicon Valley, a lot of the big Fortune 500 companies have gone to risk-based plans, which basically say if a patient has had no restorative care, no fillings, no crowns, no bridges, et cetera, no perio treatment in the past 24 months, that patient only gets one prophy and one exam per year because they are considered low risk. In order to get their 2 every 6-month prophy and exam, they have to have had restorative work done in the past 24 months. They're growing, they're increasing, and over the past 2 or 3 months, these are something that we have begun asking on every verification we do, if it is a risk-based plan, because we need to know the difference. And then it needs to be entered into your system in 2 different ways with the same group number, same coverage, but different frequency limitations. Becomes a pain because then you have to remember to switch. Oh, this patient needed a filling, so now we have to switch them to the 2 per year group instead of the 1 per year group, and it's kind of a hassle, but it's what we do because it's what we have to do in order to make sure our system is right and we get paid. So risk-based plans, 100% based on, is the patient considered high risk, low risk for prophy, exam frequencies, x-ray frequencies, et cetera, et cetera. So be sure to check about those as well. Most favored nations clauses, okay? These are very, very few and far between, but they are happening. A most favored nations clause will say, and you will see these, I see these a lot in the Southwest. I see these a lot, down in Texas, there's a few. Basically what this says is you agree to give the insurance company the lowest price you accept for each specific service. So if you did a DO 120 periodic exam for a patient and you waived the fee and you charged $0, guess what? That insurance company with a most favored nations clause should be charged for every DO 120 you do on their patients from this point forward, $0, because you agreed in your contract to give them the lowest rate you accept. Again, they are few and far between, primarily in the South and the Southwest. However, the Supreme Court has ruled that they are allowed and they are legal, and insurance companies are allowed to enforce them. So very rare, I will say, but increasing annually as new providers go in network. So as the new grads and as other docs, middle-aged docs are deciding it's time to go in network, these are getting added to the contracts. This is not a policy clause. This is a contract clause. When you go in network, it's between the doctor and the insurance company, has nothing to do with the patient's plan whatsoever. There is a question that came in. I'll hop back real quick about the no out-of-network payment clauses. In Michigan, they passed SB 350 last year. Actually, it was the very end of 2018. And what SB 350 in Michigan says is if you are an out-of-network provider who accepts assignment of benefit from a not-for-profit insurance company, which is any Blue Cross Blue Shield, any government type plan, if you accept assignment of benefits, even if you are out of network, you agree to accept the insurance allowed fee as your payment in full. There is no balance billing, even if you are a fee-for-service office. So in Michigan, do not accept assignment of benefits for those patients. Have them pay up front, have the assignment sent to the patient, they get reimbursed the full fee. If it gets sent to you as the provider, you get sent the allowed fee and you will have to accept that as payment in full. Just in Michigan right now, SB 350. So what is the process that we are following as we go through checking for all of these clauses? We're doing a verification. Okay, we are doing a 98 question verification. I'm going to show you the verification form that we use when we do insurance verifications in my office. And you will see it is a fairly extensive form. Give me 1 second. I'm just popping it up here. All right. So this is our insurance benefit verification form, hoping everybody can see it. So we ask all the basic information, what kind of plan is it, HMO, PPO, fee schedule, who are payments sent to if we are out of network or in network, who do the payments go to, who do you allow assignment of benefits to. We get all the information, the group number, the policy number, mailing address, so on and so forth. Then we get into more detailed information. Annual maximums, deductibles, has the deductible been met? What is the amount of the annual max that's been used? Are there waiting periods on basic, on major? Have they been met? Do preventative and x-ray services count towards the annual maximum? Some plans they do, some plans they do not. It is about 82% they do right now, and 18% they do not. I will say it is very geographic, so it really truly just depends on where you are. But nationwide, the vast majority, preventative and diagnostic does count towards the patient's annual maximum. So then we get the preventative percentages, deductible, is there a wait after a full mouth debridement, diagnostic, etc., palliative. I won't go through the whole thing and bore you. Check for frequencies. Exams, do they have to be 6 months apart? Does the DO 120 share with the DO 140 on frequency? Pro-fees, frequencies, history, bite wings, FMX Pano, how often can they be had? What is the history? Fluoride, again, does it have to be 6 months apart? What's the age limit, frequency, history, what teeth are covered, percentages, frequencies, etc. It's all right there. Then we get into, basic endo, perio, major, oral surgery, TMJ, implants, prosthodontics. Get the breakdown, know what the percentages are. Then we ask for specific individual codes. For each office, this is going to be different. Some offices place implants, so they need to have the 6010 implant code on there. Some offices do a lot of occlusal guards, so they need that on there. Some offices don't do any endo, so they don't need that on there. They don't do any perio, so they don't need that on there. So it's going to be different for every office, but take this form, customize it, make your own, so it works for your office. That's the important thing. Then you take this verification form, where we're asking about everything. Again, right down here is the missing tooth clauses, the least expensive alternatives. We ask about ortho as well. Are crowns downgraded? Are composites downgraded? Posterior composites. Crowns are paid on prep or seat date. This is one of the things that there is a lot of discussion about. I have seen people say it is insurance fraud if you submit a claim for a crown on prep date. That is incorrect. It is not fraud because 56% of insurance plans nationwide pay on prep date, not on seat date. Okay, knowing the answers to these questions is very, very important because here's what happens. If a crown is paid on prep, let's say it's paid on seat, and on December 15th, you prep a crown for delivery January 5th. Well, as of January 1, that patient's employer switched insurance companies, and it went from MetLife, who paid on prep, who paid on seat. Now it's gone to Guardian, who will pay on prep. Well, that tooth was prepped prior to the patient having coverage, so it's not going to be paid by the new plan. It wasn't seated before the old policy expired, so it won't be paid by them. So now nobody's paying for this crown, and the patient has just gotten screwed out of any coverage for that crown whatsoever because you didn't know, is it paid on prep or seat? Now, again, it happens towards the end of the year frequently, and it's something you really, really have to watch for. If a patient comes to you and says, hey, I'm losing my insurance, we're getting new insurance as of the 1st of the month, I want to use up as much as I can, and today's the 29th, can you do these 3 crowns that we've been putting off for a year and a half? You better make sure if they're paid on prep or seat date before you do them. This form I will post, just so everybody knows, I will post a copy of this form in the group files as soon as we're done with the webinar here today. So I'll upload it into the group files on Facebook, and it will be there. It will also be available on our resources page on our website. So we've done the verification. Now we want to get it entered. Okay. I truly believe your practice management software should be at 100% all the time. Enter the breakdown of benefits into your practice management software. You're paying for it. Use it. That way, your treatment plans are accurate. Your walkouts are accurate. If you've done the verification, if you've entered your fee schedule, if you've updated your fee schedule to the latest fees, if it's the beginning of the year, now is a perfect time to be doing all of that type of work. Get it entered so your system is right. When you do a walkout and your system says collect $112.41 from the patient, you know those numbers are correct. That's what you want to do. So get it entered into your system. It also helps with claims. Okay, if you have the insurance plans entered into the system, and again, not only the percentages, not only what's covered at 100, what's covered at 80, what's covered at 50, what does the deductible apply to, that should absolutely be in there, but also the insurance information. I can't tell you how many offices we work with that we start and they're like, oh, well, we don't have any payer IDs in there because we just print and mail our claims. Well, printing and mailing your claims today is not an option. Insurance companies are not processing paper claims. So if you are not sending them electronically, even for the emergency patients that you're seeing, if you're sending them by paper, they are not going to get paid until June or July or August, when all of this is over. People are back to work. Insurance companies are back working in their office instead of having skeleton crews working from home. Your paper claims are not going to get paid. We have one client who had their largest payment day of the year on Thursday of last week. They've been closed for 2.5 weeks, but they had their largest payment day of the year because we're submitting everything electronically, and we're also, following up on that outstanding call report, that outstanding insurance claim report. Now is the time. You have the time. You aren't seeing patients, or not that many. Now is the time to be working on those things, so those outstanding insurance claims get paid and the office still has some type of income to fall back on. It is super huge and super important, especially at a time like this. So, the claims really truly are the lifeblood of your office. You have to make sure they are accurate and they are going to get paid. So, number one, how do we make sure they get paid? Have the right information. Okay, make sure when you are submitting claims, and however you do it, make sure the information is correct. You have the right payer ID. You have the patient's right name. I cannot tell you how many claims I see rejected every single day because, somebody puts, well, this person's name is Thomas Jones, but he prefers to be called Zeke. So they put Zeke as the first name in their practice management software. Well, guess what happens when we submit that claim to insurance, but the insurance company has his first name as Thomas, not as Zeke. The claim is rejected because the names don't match, and it delays you getting paid. Now you have to resubmit it with Thomas, and honestly, how many people in your office know his first name is Thomas because he said it was Zeke? So, making sure that information is correct. Another big thing for rejections is, and every software has this, where you put the relationship of the dependent to the insurance policy holder. Okay, a lot of people will just leave that default to other. Well, if the insurance company says, we know that Tom Jr. is Tom's son, so you put spouse, or you put other, they are going to reject it because it doesn't match their system. Remember, electronic claims are posted, are very, very rarely reviewed. So, please, please, please make sure that information matches, because if it doesn't, it's reviewed by a computer. And if it doesn't match exactly, it's going to kick it out. So please, please, please make sure the information in your system and on your claims is correct. The other super important thing when you're doing claims is attachments. Okay, claims and attachments go together all the time. We have a list on our resources page of all of the services, what insurance companies require what attachments. Aetna and United Concordia both require intraoral pictures, both pre-op and post-op, for buildups for the 2950 buildups. For post and cores, they want pre-op and post-op pictures or x-rays to show why you did the buildup and then that you actually did the buildup. I will say, in their defense, this is not, and listen, I despise insurance companies. Okay, they are the bane of my existence. However, in this case, I can tell you what they are doing is warranted, because I can't tell you how many offices I have seen that have billed for a buildup with every single crown prep they have done for the past 15 years. And we all know, while you may do a lot of them, you are not doing a buildup on 100% of the crown preps that you do. But there are dentists, and more than just one or two, who bill for a buildup every single time they do a crown prep. So it's a huge pain, but in their defense, as much as I hate them, these are justified. So make sure you have the proper attachments. If you are submitting for a bridge or you're submitting for an implant, make sure you have an FMX or a Pano because they are going to want to see it. If you are submitting for a crown, make sure you have a PA. You want to have a periapical x-ray to send along with the claim for that crown to get it paid. A lot of people will take bite wings. I will tell you, I've seen way too many get rejected. Some of them will get paid, but I've seen way too many get rejected because, well, we want to see the apex of the tooth and we can't see it on the bite wing, so therefore we're not paying for the crown. It happens. It may not have happened to you, but it does happen, and believe me, it is coming. If you are submitting for perio maintenance, if you are submitting for scaling and root planing, make sure you have your perio charts and your FMXs attached. We're going to talk specifically on Thursday about periodontal mapping and soft tissue management plans, but make sure you have the perio charting. So super, super important. If you are still sending paper claims, please, please, please stop. Please stop. Unless you are charting on paper and using film x-rays, please, please, please stop. We use a program called Remote Light. It's from Renaissance that actually just got purchased by Vine, the same company that owns NEA Fast Attach. Just got bought by them. We've been using them for 13 or 14 years in every client's office across the country. It works. It works wonderfully. I can tell you I have one complaint. My one complaint is they send me too many emails telling me what's going on with their network. Other than that, I have absolutely no complaints. We know when a claim is getting rejected and why, literally within 15 seconds of hitting send. We can go on their website and we can actually look at the attachments that are attached to each claim. It is truly a great system. So, if you are still sending paper claims, especially currently, they are not getting processed, and the federal government has waived all prompt payment laws for all 50 states for paper claims sent to insurance companies. They're not processing them. If you are mailing your claims, if you are mailing your attachments, the processing time may not happen until June, July, or August, whenever this is all over and we all go back to work. So send them electronically and you will get paid faster. You need those checks coming in over the summer, over the next few months, while everything is kind of on a downhill, while we're all on hold. So, the last thing, and what I want to leave you guys with is, please, please, please do what you bill and bill what you do. That is the lesson of the day. If you are doing a veneer, bill a veneer, do not bill a crown. If you are doing a crown or you're doing a bridge, do not bill a crown. Do what you bill and bill what you do, and you will be fine. So this is, again, the beginner part, the introduction. We are going to get much, much more in depth and much, much more into detail on Thursday. So, again, I thank you. Thank you all for coming. Thank you for being here. Thank you for taking time out of your schedule for this. I look forward to seeing you all on Thursday. I will make sure the links get posted in the group. In the meantime, if you have any questions, please feel free to ask. You can reach me. My email address is rick, R-I-C-K, @practicemechanic.com. Email me your questions, post them on the Facebook group. Whatever it may be, please, please, please feel free to reach out. We are certainly here to help. It is our goal to make sure that every single dental office survives these shutdowns over the next few months. And we're going to do that by getting paid for what limited work we are doing now and collecting payment for the work we've already done and keeping it coming in. So thank you again. I look forward to seeing you all on Thursday. This video will be posted on the Facebook group in the next hour or so. So thank you again. Have a wonderful day, and I will see you all on Thursday.